Morning, everybody. How is everybody doing?
Morning, Bryce.
Morning.
How are you?
Good.
Nice. It's Army theme today. I forgot my fatigues. Dang it.
Uh-oh.
Morning.
I like this filter, it like darkens out my eyebrows and everything. Make me look like Charlie Chaplin. I don't know. Here's my buddy, Major Pain, which considering we're doing inflammation, I don't know, somehow seems appropriate. But today's theme is inflammation. And like I probably explained to you during lab yesterday, we're not going to talk about the musculoskeletal. We're going to talk about a concept, inflammation. And we're going to use the examples of rheumatoid arthritis, osteoarthritis, and gout. Now, rheumatoid arthritis is an autoimmune disease. And I think gout is maybe in that category too. So those things that are caused by viral infections and stuff, we'll study at 10 o'clock when we study infection. But here's a couple of examples of inflammation, which I am sure is something that all of us are familiar with, especially after that 5-mile hike on Mount Rainier. We start taking vitamin I, ibuprofen. Okay, what we're going to cover today, we're going to look at inflammation. We're going to look at rheumatoid arthritis, which they also call RA. A lot of people just refer to it as RA. Osteoarthritis. Osteoarthritis is that one you get from like wearing your knees out, sports injuries, stuff like that. Basically, it's just overuse. I know this topic intimately. And gout. Gout is not fun. Anybody out there ever have gout or know somebody with gout? Yeah, it's not enjoyable. But let's take a look. Aha. If you see Arlie Ermy here in anything, you might want to remember it because it might be on a test or something. I don't know, maybe. So let's start. What is inflammation? Inflammation basically is that's the body's protective response to an injury or an infection. What's happening during an inflammation is you're basically just rushing a lot of your body's protective mechanisms to the site, and it just causes that area to swell. We'll talk more about that. It tries to eliminate pathogens. That's where it's rushing white blood cells and stuff to the site, and for tissue repair. That's where it's rushing blood and nutrients to the site to help repair that site. What do we do as nurses? As nurses, we identify people at risk for inflammatory response, hopefully preventing it from happening, or help that inflammatory response once it happens. And it could be something as simple as putting ice on a swollen ankle. Moving on, let's start with rheumatoid arthritis. Anybody know anybody that's had RA in their life? It's not fun. It is not fun at all. It's a systemic inflammatory disease. I'm not sure they define it as autoimmune. Yeah, it's an autoimmune disease. We used to believe that what happened is somebody would get a Staphylococcus aureus infection. Anyway, they would get an infection and the body would rush out there with the immune system to try to kill the bacteria. But since the staph is very similar to the cartilage, the chemical makeup of it is similar to cartilage, the body got carried away and attacked the cartilage too, instead of just attacking the bacteria. So what happens is your body is literally eating away at the cartilage in your body. I don't think that's the standing theory nowadays. I think they're not really sure if that's exactly the case. So the cause of it is kind of unknown or kind of up in the air. but they know what it does, and that is your body is basically digesting the cartilage in your joints, which causes a great deal of inflammation in the body. Like I said, RA attacks the joints and surrounding muscle tendons and ligaments. Very crippling. You'll often see people with their very characteristic. You see their hands kind of have that tilted look to them when you see somebody with a really severe RA. Their fingers kind of go off at an angle, and that's a dead giveaway that they have RA. Here are the different stages of RA. You're not going to be expected to know these stages, but it's more for your own information. But the body mistakenly attacks its own muscle joint tissue, and then it manufactures antibodies to attack that cartilage. And when it attacks that cartilage, it causes inflammation in that joint, and the joint will swell up, especially like in knees, toes, not so much toes, but knees, finger joints, any joint in the body. If your joint does have a synovial area, the synovial packet that I showed you last week on the knee joint, it'll cause that to swell. It causes bone erosion. Eventually, it's going to be bone on bone, which is not fun at all. The third stage is where you start seeing the fingers kind of turning off to the side, and the joint becomes really misshapen. It also gets really red and swollen. If not treated, basically, you just, like you said, you eventually become just bone on bone, which is very crippling. It's a horrible disease. I mean, I really, my heart really goes out to people that have RA. Assessment, one of the very first signs for RA is actually when your body launches the immune response or the autoimmune response, and that results in fatigue, malaise, low-grade fever. Another way of thinking of this is flu-like symptoms, and that's because your body is doing the same thing it would be doing if you had a bacterial infection, or if you have a virus like the flu. Anytime you get any kind of infection like that, these are the normal signs and symptoms you would get with the flu or the cold or anything like that. You're actually, what's causing your fatigue and malaise and fever and all is not the disease itself, it's your body's response to the disease. Not a lot of people know that. It's kind of more of a process of elimination. The doctor looks at the symptoms and kind of figures out you have RA. Now, there's a lot of diseases out there, especially autoimmune diseases. When we study lupus and such, they run labs and tests to find out what it's not. And when they've eliminated everything else, they come to the conclusion that you have chronic fatigue syndrome because you're not testing positive for anything else. So it's a process of elimination. A lot of medicine is process of elimination. The reason I want to point this out is because patients are going to look at you and say, you've run 5 or 6 different tests on me and you still can't figure out what it is. It's healthy to explain to the patient that that is how we are figuring out what it is. When you have things like lupus, chronic fatigue syndrome, rheumatoid arthritis, there is no test that we run that says, this is it. So what we have to do is, through process of elimination, find out what it's not. And that's how we make the diagnosis. So sometimes it's healthy to explain to patients that, well, what's going on is we're trying to find out what you have through process of elimination. So, you know, there's several things out there in the world that people have commonly that we just can't, you know, take a blood test and boom, this is what you got. It's not that easy. The body is not that easy. However, individuals, there is a blood test, which is called RA factor. And in rheumatoid arthritis patients, you know, about 75 to 80% of those patients will come back positive for that, but that's in the later stages. So when this first starts happening, we don't have a concise test just for RA. And still you have that 25 to 20% of the people where it doesn't come back positive, but they still have RA. So, I mean, pretty soon you'll develop signs and symptoms that it's, you know, it's obvious you have RA, but there is no definitive test for that. So that's just kind of a teaching point. you're going to be explaining to a lot of patients that, yeah, we're running 8 or 9 tests on you, but diagnosing this disease is a process of elimination. So bear with us. They may buy it, they may not. X-rays help as far as assessment goes, but there again, the joint has to already be degraded before it shows up on the X-ray. So in the early stages, stage 1, stage 2 of RA, it's not going to show up on the X-ray. That being said, does anybody have any questions on that? Nope, you're all awful quiet out there.
Okay, I just want to clarify real quick. Sorry, when you were saying before about Staphylococcus aureus, that was just a theory. It's not like, oh, this is what causes it, right?
Yeah, and I'm not sure I
Okay.
have the right bacteria. It could be in Enterococcus. I can't remember which one it was, but
Okay.
it was the theory that I think it was a staph infection. They used to think if
Okay.
you got a staph infection and then your body launched a response against it, and it would mistake the cartilage as the same molecule as staph and attack your
Okay.
cartilage. That used to be a predominant theory, but what I've been reading lately is that they're not so sure about that.
Okay.
Now, we do know that something will trigger it. I think there's also some factors in there as far as genetics. Genetically, you might be predisposed to it.
Mm-hmm.
So, how does that factor into all of it? I don't know. It's just
Okay.
when it comes to autoimmune diseases, a lot of those are a big mystery. Lupus, chronic fatigue, RA, autoimmune disease. I mean, somehow your body just starts attacking itself. And it's like, okay, why are you doing that? Sometimes it's clear, sometimes it's not. And if you get Lyme disease, yeah, it's pretty obvious what's doing that. But I mean, if you get chronic fatigue, it's a big question mark. Maybe that's why they call it practicing medicine instead of doing medicine. I don't know. People joke with me all the time. Say, is this why they call it practicing medicine? Yeah, whatever, dude. Take your medicine. Be quiet. Anyway, you might want to remember that one. I love that. I heard R. Lee Ermey passed away. That was really sad. I like that. For anybody who's not familiar with him, he's the drill sergeant in Full Metal Jacket. Oh my God, he was awesome. Anyway,
he's not a really quotable guy for the class, that's for sure.
What's that?
He's not a quotable guy for the class.
You know who I'm talking about, though, don't you, Trevor?
Oh, I love that movie. Great movie.
Mm-hmm.
It was brought up in my basic training a lot.
I think it's required viewing for anybody who's been in the military. Okay, how do we manage this on a medical level? Remember, we're talking about 2 levels. We're looking at the nursing level and the medical level. The medical level, we're going to use NSAIDs for the inflammation. In the beginning stages, you might want to use ibuprofen or an anti-inflammatory of that nature, but eventually the RA moves on where it becomes extremely progressive and we start using the real high-powered anti-inflammatories. There again, corticosteroids. You start out with aspirin, you start out with ibuprofen, and then you move on to corticosteroids for inflammation. Some of you are probably familiar with that when you're dealing with the asthma. Corticosteroids are like prednisone, solumedrol, the corticoid shots that they give in your knees. If you ever had a sports injury and they want to do a steroid shot in your knee to help the inflammation go down. Corticosteroids are really excellent for reducing inflammation. They also have a lot of awful side effects. People that are on prednisone for a long time develop a lot of bad side effects. So it's not the greatest medication in the world, but they're always coming out with better anti-inflammatories with less side effects. So we just kind of roll with it. Disease-modifying anti-rheumatic drugs. Now, I think there's more slides in here on that, so I'm just going to kind of blow over that and we'll get more detail on that as we go along. Maybe, I can't remember. But anyway, these drugs are actually a immunosuppressant. So like if somebody had a kidney transplant, and they take an immunosuppressant drug to keep the body from eating the kidney because it sees it as a foreign body. I'm sure you're probably all kind of familiar with that. You know, if you have an organ transplant, you have to take immunosuppressant drugs to keep your body from destroying that organ because it doesn't have the same DNA. So it thinks it's a pathogen and it tries to destroy it. So you have to take drugs to keep your immune system from trying to destroy that organ. The same applies to RA. I mean, your body's trying to destroy, through your immune system, is trying to destroy your cartilage. So if you can suppress the immune system, then you can help prevent the body from doing that. You know, the problem with immunosuppressant drugs is if you're suppressing your immune system, you know, what are you doing? You're opening yourself up for any other kind of infection that may come along. So people on immunosuppressant drugs have to be very careful about, you know, being around people with the flu, about infections, about things like that, because their immune system is not operating normally. What are we going to do as nurses? One nursing diagnosis you could use for RA patients would be pain, management of pain. We are helping them with their NSAIDs, their corticosteroids, their immunosuppressant drugs, because we're giving them to them. Even if you are discharging the patient, it's your job when you discharge the patient to give them instructions on the drugs that they're going to be taking. Now, the pharmacist will do that too, but I always like to just give them a little, you know, familiarization. You know, if you're going to take ibuprofen, be careful. Aspirin affects your bleeding. It affects your stomach. Put some food in your belly first, stuff like that. Impaired mobility, of course, is a nursing diagnosis because, you know, if your joints are seizing up, you're not going to move as well. I don't know if exercise is good for people with RA. I would imagine it is. I know it is with osteoarthritis. Osteoarthritis is extremely important that you keep those joints moving. But RA, I'd have to go back and look it up. I think it is good for the tissue for you to do that. And nutritional deficits, just because of the pain and such, individuals with RA have a tendency to get a little malnourished. I mean, if they have someone fixing meals for them and stuff, it's not as bad, but still just picking the spoon up to put the food in your mouth and stuff, it gets to be tiring and they can suffer malnutrition. So their caregiver has to really pay attention to that. Any questions on RA before I move on? You guys are lucky. We used to have like a whole section on the immunosuppressant drugs, which just like makes your mind spin when you, I did away with that because we don't need that.
Is RA a curable disease or is it incurable?
It is not curable. It's just like cancer. It's chronic and it's progressive. We do not have a cure. At this point, we don't have a cure for it. I'm holding out hope. A lot of the genetic engineering we're doing, and if you read about CRISPRs, CRISPR, it's actually the lady that came up with CRISPRs just got a Nobel Prize in chemistry or biology for coming up. But a CRISPR is a chemical that will actually splice RNA and DNA into a cell. So as we get more and more, get better at genetic manipulation, there may be a possibility that maybe help avert this. I'm also hoping that, you know, growing cartilage in a Petri dish, that eventually we'll be able to grow cartilage and insert that in certain joints. I keep waiting for that because I don't want to operate on my knees. So I'm hoping they'll learn how to grow cartilage so I can just have that inserted in my knees. I don't want an artificial knee. Look like Terminator. Anyway, moving on to osteoarthritis. Now, osteoarthritis, this is the use injury. This is a degenerative disease where we just plain wear out the joint. Speaking of military, since we're on military theme, when I was in the Army, I was a parachutist. And parachuting, you hit the ground real hard. And after you've done so many parachute jumps, you pretty much trashed your knees. So it's extremely common for anybody who is in the airborne units in the military to have osteoarthritis of the knees. It just trashes them. You'll also find this in football players and any kind of sports activity that just hits a certain joint a lot. You know, baseball pitchers and their shoulder. You're basically just wearing the joint out. It comes with age. We all know older people where their joints just start getting stiff and, you know, oh, it's going to rain. I can feel it in my joints. Obesity, of course, obesity there again, the obesity is wearing out your joints. Usually with people who are obese, they'll wear out their knee joints. Injuries can cause it, and genetics. There's a thing called Piaget's disease out there. If you want to read up on that, you can do that. These all contribute to arthritis. If we all live long enough, we're all going to have osteoarthritis in one place or another. Oh, might want to remember that. Okay, here's an example of osteoarthritis. Yeah, where did my cursor go? There it is. Basically, the joint is just wearing out. You get erosion. Now, normally what will happen is you will start, you'll wear out the cartilage, and then after the cartilage wears out, the joint narrows, and then you can actually start eroding the bone tissue itself. And you can also develop, these are spurs. Osteophytes are a bone spur that can develop from the degeneration of the joint. We all know about bone spurs, don't we? So that is an example of a bad joint right there. Basically, you're just wearing your joint out. Assessment: stiffness, pain, irritation, crepitus. Everybody know what crepitus is? If you don't know what crepitus is, the next time we have lab, I'll let you listen to my knee. Boy, it sounds like a bowl of Rice Krispies. Somebody else, when the joint wears out, you'll hear it go crack, crack, crunch, crunch, crack, crack, crack. That's called crepitus. And you can also, when they start developing from that irritation and the inflammation, you can start getting nodes. If it's down here at the end of your finger, it's called a Heberden's node. If it's further up, it's a Bouchard's node. I actually think that these doctors just wanted their name on something, so that's why they invented that. X-rays will show up. I've had my knees x-rayed several times. So it's really a good diagnosis for osteoarthritis because, I mean, it can tell you, for example, in one of my legs, the degeneration is the knee cap. The patella is bumping up against the bone. So it's really not in between the joint. It's not between my tib fib and the femur. This is a problem. It's actually the kneecap itself is rubbing against the joint. So x-rays are really good for seeing, okay, exactly where is the degeneration? Because you don't want to go in and operate on the knee when it's actually the kneecap that's causing the problem, obviously. So x-ray is usually the most concise. I mean, there's no lab test for this, obviously. Okay, why do you manage it? NSAIDs. NSAIDs are your aspirin, Tylenol, ibuprofen, Motrin, etc. Just as a general statement, this is just kind of a sidebar. I've never found Tylenol to be real good for joint pain. And in fact, aspirin is really not real good for joint pain. Ibuprofen seems to be the best because it's more of an anti-inflammatory than the other three. Anybody else have that experience?
Yes.
We have any long distance hikers out there? Yeah. Most sports people into sports or especially outdoor activities, it's usually ibuprofen they reach for first when they have muscle cramps, joint pains, etc. Tylenol is good for a headache. In my opinion, that's about all it's good for. Heat and rest is good for the joint. We all know we can put, a hot pack on our knee joint and that'll help it feel better. And just resting it. However, not too much rest. Exercise is the way to go. My father had really bad arthritis of his fingers. he was a tool and die maker, and I'm sure that he probably used his fingers a lot in that profession. But it really got bad after he retired. So he took up gardening. Gardening, you grab weeds, you're pulling weeds all day long. So it's that exercise of those joints that actually helped his joints better than anything. If you know anybody with osteoarthritis, get them to use that joint. What that does is that causes the muscle tissue around there and the joint tissue to secrete the liquids that help lubricate your joint. So it helps keep that joint from becoming stiff. The worst thing you can do is sit there and not use it. It's just going to get stiffer and stiffer. Moving on. Alternative medications. Okay. Who was it that was asking me about it? It was you, wasn't it? Trevor, you were the one who was asking about. Yeah. There you go. There's your CBD oil.
Yeah, I'm the future cannabis nerd in the class. Yeah.
Yeah, I thought it was you. Oh wow, now you can see. Okay, yeah, I see where they put the coloring over my mustache and stuff. I really didn't dye my beard. It's a filter. It's a really good one too. CBD oil, you can either take it orally or you can get lotions where you rub it on the joint. I've used some on my knees before. It seems to work pretty well. It's pretty good.
The only issue is some of them you can, like, I don't use it anymore because obviously I will be drug tested at some point again, but it smells like weed. You can smell it. So you smoked the joint when you didn't. So I mean, yeah, I guess that's one of the drawbacks. Is like
that would be a concern.
You got to tell them to find something that doesn't smell like a dispensary.
Another alternative that I forgot to add in here that I use all the time, of course, is chondroitin and MSM. That's a natural supplement. You can buy it at Walmart. And I used to have to, before going to bed, I used to have to take ibuprofen, to get the muscles to relax and the joints to feel okay before I could go to sleep at night. And I was really worried because ibuprofen really impacts your kidneys. I mean, taking ibuprofen is like, drinking a 6-pack of beer. So I didn't want to impact my not beer, that's liver. I'll take that back. Anyway, it impacts the kidneys. So I wanted to find an alternative. So instead I take a couple tablets of chondroitin MSM combination at night. And that seems to work quite well. It really works for me. So, anybody with arthritis. And joint replacement. Yeah. Oh boy. I'm sure we'd all look forward to that. Now, remember last week I showed you the artificial knee and the hip. A lot of people get arthritis in the hip. They have artificial hips. It's really bad. I mean, it gets down to where you're just bone on bone. Yeah, that may be your only alternative. Put it off as long as you can. Nursing management, chronic pain, assist with pain management, medications, educate on heat rest. Also, I would add in here exercise. I forgot to put that in there, but do emphasize to them that the best way to treat that joint is to just keep that joint moving. I can't, and you might run into this with patients, you probably can't do high impact stuff anymore. Like I couldn't run or play basketball with an arthritic knee, but I would be able to walk and hike. So the exercise that they use for that joint will probably have to be a low impact exercise. It's really frustrating when people who are long distance runners get chronic knee problems or joint problems because, they might have to give up the running and just go to walking. And that can be really frustrating for somebody who's a committed runner. Impaired mobility, obviously there again, exercise is the best way to treat that particular nursing diagnosis. And self-care deficit. Remember we were talking about RA, the individual having trouble eating and get malnutrition. The same thing kind of happens with people that have really, really bad arthritis. They can't reach stuff on the upper shelf. Self-care, it's kind of hard to wash yourself or brush your teeth or anything like that. I think I have some devices here. But here are some stuff that they can get at the usually medical supply stores to help them out. they have really bad arthritis in the hand. It's hard to grab doorknobs and turn them. So here's a device right here that will help them open doors or turn doorknobs. Another good thing to do is recommend that they get rid of the round doorknob and put in those doorknobs that have the handle, because then you can just push down on the handle with the butt of your hand, in and out of doors. Putting on socks and putting on shoes. That's a real problem with people with chronic arthritis, especially if they have back problems. There are devices here. There are shoe horns, of course, for getting your shoes on, but this one was designed to help you put your socks on. You put your sock on this and then put your foot in it and pull it on, and it helps put your sock on. Quite cool. Silverware, the little dinky silverware that most of us have. It's really hard for people with arthritis in the hand to, let me check my time here. Okay, I'm gonna have to speed up a little. I'm taking too much time. But there's silverware out there with big handles. Makes it easier to grab for eating. This would be really good for RA as well. Okay, last one. Last but not least, gout. Ooh. I had a hiking buddy who had gout, and he would get that occasionally. And it was in his right big toe, I believe, and it just made his life miserable. But basically, it's inflammation that's caused by the deposit of uric acid crystals in the joint. And uric acid is a byproduct of metabolism. As you break down protein in your body, you create uric acid. Pretty sure I'm right on that. Anyway, it goes around your body and it can form crystals that deposit themselves in the joint. Most often occurs in males over 30 years of age. And risk factors: diabetes, obesity, high blood pressure, leukemia. Y'all know this abbreviation, right? Hypertension, high blood pressure. These are individuals that stand a higher risk of getting. Now, my buddy didn't have any of these. Like I said, he was my hiking buddy, so he was pretty good on all that stuff, but it can hit anybody, although he was a male over 30 years old. And things that will aggravate it: stress. Purine is a chemical in some foods that aggravate it. You would have to look that up, because off the top of my head, I can't remember what foods have purine and which ones don't. I'm gonna have to look that up, aren't I? Yeah, I better. Anyway, there you go. Homework. Dehydration is not good. Dehydration will affect it. And alcohol and caffeine. And I think my buddy, he loved his vodka gimlets. So I think this was his problem here. He loved those vodka gimlets. Anyway, alcohol and caffeine can aggravate the situation. And as with my buddy, it kind of comes and it goes. You'll be okay for a while, then suddenly you have an attack. And it's like, oh, you're miserable for like a month or two, and then it goes away. And it can come back and it goes away. So it's kind of irritating. So here are some of the factors that can cause gout. You might want to remember those. Hint, hint. Nod, nod, wink, wink. How to assess it?
I have a quick question, Bryce.
Sure.
I mean, I think you said we need to look that up, but the purine, like, is that like the purine in foods is like fish, like it can be found in
I do
fish?
believe it's fish. I remember salmon, I think, has a
Right.
lot of purine.
The book says it's sardines, shellfish, steak, and something else.
Yeah,
Okay.
purine foods, I'm looking it up as we talk. As you're saying that, it's kind of coming back to me now. But I remember seafood. Seafood was a real big one. Let me scan down here real quick and I'll take a look. Of course, they have to blah, 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 blah before they get to the point of anything, you know. That's how internet is nowadays. You look up a recipe for food, there's an article this long before they ever get to the darn recipe. Anyway, you guys can look it up if you want. But I remember seafood was a big one. And that was kind of bad, because one of my buddy's favorite hiking foods were those little tins of sardines. And he used to pull that out of his pack, and I go, Perry, what are you doing? You're not supposed to be eating that stuff. You've got gout. Compliance. Here is a classic example of gout right there. That could be on the hand, that can be on the toe. It's usually the smaller joints that get that, but oh boy. X-rays will show it. There is a uric acid test. If your uric acid test comes back greater than 7, you're at risk for gout. That's not a real diagnostic test. It doesn't say, oh, your uric acid is 8, so you've got gout. But it can tell you if you're at risk for getting gout. Or they can just take a syringe and shoot straight into the joint and extract some fluid. And then they run that fluid through a test and see how many uric acid crystals you have in there. How do we manage it? Anti-inflammatories, there again, anything anti-inflammatory, ibuprofen works really well. If you give ibuprofen or an NSAID to somebody, do caution them about the risks, gastrointestinal risks, impact your kidneys if it's ibuprofen, impacts your liver if it's Tylenol, etc. Colchicine, this is the main treatment for gout users, right there, colchicine. It helps reduce the uric acid and hopefully helps with the joint. Kind of works sometimes. No, it's not a miracle cure. It doesn't work all the time, but it helps. It helps. Kind of just like NSAIDs. Hopefully it makes it tolerable. Nutrition, stay away from foods with purine, stay away from alcohol, stay away from caffeine. As much coffee as I drink, I would be toast. Surgery, they can actually go in and repair the joint if they need to. Hopefully it doesn't come to that. Nursing management, impaired mobility, bed cradle. You're going to see this in the hospital. Now, the bed cradle they're talking about there is if you're laying in bed and the sheets fall on your toe, it could feel like a sandbag. Very, very painful. So we put a rack, just like, a rack they use for pizza in the pizza restaurant, and we put that over their feet and then put the sheet over the rack, and that keeps the sheet off of their toes. And now you see why I'm a nurse and not an artist. So that keeps the sheet up off of their toes to keep it from hurting. Hot packs, cold packs, I would just ask the patient which one they prefer. They probably know from experience which one helps that joint to feel better. Cold packs reduce the inflammation. Hot packs help increase the circulation. One or the other is going to help them feel better. But this is more just a comfort measure than anything else. Pain medications, NSAIDs and colchicine, which we've already talked about. And knowledge deficit. We finally get to use a knowledge deficit nursing diagnosis. You'll use that one a lot. Put that in your little bag of tricks in the back. Knowledge deficit. You always have to teach the person about their disease. You have to teach the person about their medications. So that's a real good nursing diagnosis if you just can't come up with anything else. Anyway, warn them about dehydration, drink plenty of fluid and water, stay away from seafood, stay away from alcohol and caffeine, and then educate them about the different lab tests and medications that they'll be going through. Any questions on gout?
I have a question, Bryce.
Yep.
With the gout, you said that I just need some clarification because you can have flare-ups. So once you're, if you're get the uric acid or the whatever test, you might be at risk for. But if you fully get gout, will you always have gout because you just have flare-ups, or is it just one of those things where you can get rid of it by lifestyle management?
In a way, it's a lot like diabetes.
Oh, okay.
If you got it, you got it. Now, if you really manage carefully, you stay away from seafood, alcohol, caffeine, keep your stress down, you won't get as many flare-ups. Hopefully you won't get any flare-ups. That's not likely. It's like I said, me and my buddy, my hiking buddy, we would be out all the time. And then just like every once in a while, bam, it would hit his toe. And like for about a month or so, he'd have to take it easy, take his colchicine, take his anti-inflammatories, watch his diet, and then it would eventually recede a little bit, and then he could move on. Unfortunately, there's no cure. I mean, just like arthritis and RA, you know, once you got it, you got it. Now, all of these RA, osteoarthritis, gout, and stuff, these aren't like bacterial infections or anything, so we can't like give you an antibiotic and make it go away. Once you got it, you pretty much got it. Other questions? Let me stop the recording.